So thank you everyone. I declare the meeting now open to the public online. I'd like to welcome members who are participating in person or by video conferencing. I'd like to remind members about the protocols regarding the use of electronic devices. So we have one apology today from Carol Ní Cullen, and Carol has assigned her vote to me should there be a vote on any issue. And are members aware of any other apologies? No? Okay, thank you. Okay, members, so today we are taking a briefing from the Royal College of Surgeons. Today's session is specifically in relation to the winter surge pressures, and I refer members to papers at tab 2 of the pack, which include a briefing paper from the Royal College at tab 2.1, a copy of the Minister's written statement on winter preparedness and winter surge plans at tab 2.2, and copies of the Trust delivery plans, which are at tabs 2.4 to 2.9. So I'd now like to welcome by Starleaf Mr Mark Taylor, who's the NI Director of RCS England, Mr Isaac Phillip, who is a paediatric surgeon, Mr Tim Mitchell, who's RCS ENG VP and ENT surgeon, Mr Mano Shanmuganathan, who's a neurosurgeon, Mr Brian Duggan, who's a urologist surgeon, and Mr David Swain, who's a trauma and orthopaedic surgeon. So I will go back then to yourself, Mark, in order to address opening remarks, and then we'll go to members for questions, please. Thank you.
Good afternoon, Mr Chairman and members of the Health Committee. It gives me a great honour to present to the Health Committee today on behalf of the Royal College of Surgeons, and as you have said, Chair, delighted that we are joined by members of our board and indeed Mr Tim Mitchell, the Vice President of the College of Surgeons of England. Could I first of all, Chair, pay tribute to the many healthcare workers in all aspects of our health and social care at this precise time, as we face pressures never seen before in these shores. Not only the effect of the COVID pandemic and the brutalising effect that it has had on staff and on our society as a whole, but also the pressures that one was used to in the depths of winter having come upon our shores in the end of July. And on top of that, the difficulties of trying to sustain services have led to a moral distress in our ranks. It should be noted, however, Chair, that each and every day we see examples of fantastic practice and determination and professionalism to carry out the duties that bestow us. Throughout the pandemic, the Royal College of Surgeons has been determined in its efforts to ensure that surgeons and surgical teams are supported in delivering vital patient care in the most challenging of circumstances. I'm indebted to the Health Committee for its scrutiny over the last 2 years and also pay tribute to the Minister and the Department for the efforts as we all try to make use of the difficulties that the COVID pandemic has shown. The Northern Ireland waiting times were tragic before COVID and unfortunately they are now much worse. Waiting lists are at an all-time high. 474,445 people are waiting for surgery or a first appointment with a consultant, and that's based on the figures from November 2021. We support the Minister's elective care framework launched during the summer, and we are mindful that aspirations have been curtailed by the current pressures we face. We know our emergency departments and ambulance colleagues are facing the most immense pressures. We know about the pressures in social care and primary care alongside the volume of delivering intense vaccination programmes. And indeed, only this week, we hear of a new variant, Omicron. COVID-19 has deeply impacted levels and capacity of elective surgery like never before. It's been stripped down to the very basics. We have elective surgeries, including red flag cases, for example, cancer, regularly being cancelled. We have record attendances in the emergency departments, and I would suggest, Chair and members of the Health Committee, that in part the waiting lists and the inability to deal with people in surgical terms is further burdening the emergency departments as these people seek constant attention for the very condition that we have the ability to rectify. We are aware of the infection control measures and the difficulties in maintaining a workforce as a result of that. The question is what should be done, and we thank the Chair and the Committee for giving us the opportunity to present today to talk about the 10 points action plan for the recovery of elective surgery. We are extremely mindful that at this time where the system is under so much pressure, a quest to have a single vision of restoring surgery at all costs would be naive and indeed not helpful. And in fact, we are turning our attention to what we can do in the post-winter period around the recovery of elective surgery. But I hope you won't mind if we concentrate today on the strategies around the investment in workforce, the bed capacities, the use of COVID light sites and surgical hubs. This will make surgical services more sustainable and independent to the pressures that we're all experiencing in the unscheduled arena at this present time. And it will also future-proof the service for further pandemics or other winter pressures as they can arise. Timely access to surgery is key to the Northern Ireland recovery, including our economic recovery. The government should publish an annual report setting out its response to the elective backlog in Northern Ireland and increase the data transparency. A data system that is interoperable with other health collecting systems in England, Wales and Scotland is critical to understanding how we can improve and develop the very best in patient care. We should outline what support is needed for people as they're on those waiting lists, linking in with charities such as Versus Arthritis, the British Heart Foundation, and so many others to try and keep people well as they're on their waiting lists, exercise, physical activity programs, mental health support, and the like. We are doing some surgery, and we have to pay testimony to our colleagues who are trying their very best to continue surgery. But the numbers of COVID in our environment make it difficult to really increase the number of surgical procedures. And with that, we're aware of the workforce. The recruitment and retention of staff must be at the very core of our plans to establish the recovery of surgery. And there must be a statutory duty on government to publish regular assessments of the current health and workforce projections and indeed requirements. We are conscious of moral distress in our ranks. That moral distress comes from having a set of abilities, knowing what is needed to be done, but finding it impossible to carry out such actions. There is some good news. We really welcome the 3-year budget cycle, and we praise our colleagues in the Assembly for bringing about that ability to have sustained recurrent funding that will allow far better investment and planning in our health and social care services. And during the pandemic, COVID light surgical sites have provided some extra capacity to allow the continuation of elective surgery. We make note of the Lagan Valley Ambulatory Centre. We make note of the Belfast City Hospital Green site and also the latest announcements of Musgrave Park and Omagh Primary Care and Community Complex. We offer to the Health Committee today the recommendation that surgical hubs must be adopted throughout Northern Ireland, such as dealing with orthopaedics, dealing with cancer, dealing with benign conditions which have been greatly affected through this pandemic. The public want their operation in a hub that is safe. They are willing to travel. They've been gracious enough to tell us that. And a Department of Health survey and press release said that 82% of people surveyed thought that a journey time of up to 1 hour would be acceptable for getting that right treatment by the right person in the right place. The collection and publication of statistics such as the number of cancelled operations should be resumed in order to monitor performance, to look for efficiencies in our system, and to give confidence to our population that we are dramatically trying to redress the problems of our waiting lists. And finally, Chair, before opening to questions, I should mention our surgical trainees. No training today means no surgeons tomorrow. And our trainees have suffered immensely through the last 2 years, both with the cessation of elective surgery and indeed the redeployment to deal with the COVID pandemic. And if we do not look and address the training issues of the doctors today, then we are going to have a major workforce problem in the future. In summary, Mr. Chair, members of the Health Committee, it is an honour for us to come and present to you today. We have representation for a variety of surgical specialties with us, and indeed our Vice President, and I thank you for the opportunity to present. Thank you.
Okay, thank you very much, Mark. And I have to say, I think on behalf of the committee that the whole issue around waiting lists and how many of our population are on waiting lists would have been, I think, the major focus of the committee, and still needs to be a major focus. And while I acknowledge what the difficulties that COVID is creating, I think it's an issue of such massive importance, and that's the context in which I welcome this session with yourselves here today. This is a further engagement with yourselves, and I know you have actively engaged with the committee at various times across the pandemic, and that has been hugely welcome and hugely beneficial to us. So I want to thank you for that. And also then too, the other thing I think is that you have been particularly active in terms of coming forward with solutions rather than simply, I suppose, highlighting the problems. And I think that's the space we all need to be in, is around what it is we can do, short, medium and longer term, to drill into and press down on the waiting lists, which I think we all agree are at present totally unacceptable. So thanks for that, and thanks for your opening remarks. A couple of questions from myself, and then I'll go to members. The first one, you had mentioned there that there was significant gaps in the health and social care workforce. Where are the key gaps in those from your point of view, Mark, and how could those be addressed in both the short and the longer term?
Chair, I'll start off in the answer of that question, and some of my colleagues may want to come in. I think as surgeons, we require not just the surgeon, we require the theatre operative team, which is the anaesthetists and the nurses. And the biggest workforce dilemma that we currently have is in our nursing workforce, in our perioperative nursing workforce. And that is multifactorial in terms of why we've seen that situation. That I think it's recognised that perioperative nurses have a large amount of skill in dealing with patients who are asleep on an anaesthetic machine, and I think throughout the pandemic would have been the first port of call for redeployment to the COVID intensive care units to work alongside the intensive care nurses. The difficulty with that is that in many cases those nurses were redeployed a number of times, and I believe that in part has led to nurses having left the service. And secondly, we are aware that nurses, in terms of perioperative theatres, have not enjoyed the same degree of promotion that was offered to other nursing fraternities, and I pay tribute to the Chief Nursing Officer and the perioperative work that has carried out looking at perioperative nursing careers and how promotion can work within those careers and how to make them ideal for the future. Chair, I'll maybe see if one of my colleagues wants to come in. David Swain.
Mr. Chair, thank you for the opportunity to meet. I'll not reprise Mark's statements. Move on, you have our written evidence. To put some flesh in those bones of those nursing figures, pre-pandemic Musgrave Park Hospital, which provides somewhere between 2/3 and 3/4 of elective orthopaedic activity for the province, had about 100 or just over 100 perioperative nurses made up of theatre nurses and recovery nurses. Presently, we have 14, so 14 nurses out of over 100. 40 of our nurses are redeployed across the Trust in other areas, some in COVID ICU, some in other ICUs, but more nurses are deployed in other surgical arenas to allow other colleagues to get on with their work. Very sadly, 31 of our 100 nurses have now left, and many of those have actually left nursing completely. They have given up their registration. So of those 100 nurses that we had in Musgrave Park in early March 2020, we are down to 15, and we now face a prospect of, even if every one of our nurses was given back to us, we can only get back to 70% of our nursing body, and therefore 70% of our workload. At this stage, we're meeting to talk about winter pressures. I would have to suggest to you that at this point in time, trauma and orthopaedics have no plan for winter pressures, because what we have done repeatedly over the years is downturned elective activity to allow us to deal with an increase in the trauma, which we usually see over winter, but perhaps not as much as perhaps could be anticipated. But because we are not doing any elective activity essentially across the province, we no longer have that decant. So I really do not know how we can plan to adapt to winter surges, certainly across trauma and orthopaedics, because we do not have any more opportunity to decant fresh fractures to elective arenas because they are shut.
Yeah, thank you. And those are shocking figures and hugely worrying figures. I have to say that level of impact, and I'm very conscious of the impact that Mark, you referred to, the knock-on impact into emergency departments in terms of managing the conditions which require surgery or require an appointment of some kind. And I'm guessing that's also a factor within the GP, that the GPs are also picking up a lot of that management. And those pressures there, but also I'm deeply conscious of the issue of patient harm. And have you an assessment of what level of patient harm is being caused as a result of the gaps? And for example, I'm aware, even within my own constituency, but even wider across the north, of huge amounts of children who are not getting dental procedures carried out because there's no anaesthetist, because and I'm deeply conscious of those types of harms and those types of pain and suffering that are going on out there. So what would your assessment be of that? And I did see an indication from one of the panel there.
Yes, Chair, if you mind, I'll bring Brian Dugan in to start that.
Brian, go ahead, please.
Thanks, Chair, and thanks for the opportunity to present. Yeah, this is very pertinent in our specialty. We cover cancer and a significant amount of what's so-called benign conditions. But these benign conditions have now repeatedly not been prioritised. I'll give you some very simple examples. One would be kidney stones. And patients suffer a lot of pain, therefore they go to their GP and they repeatedly go to casualty. They're constantly told, we need to do a procedure to remove your kidney stone. But then when it comes to prioritising lists, a cancer case inevitably, these are difficult issues, but if we have a young man with a testicular tumour, that young man must go ahead of the patient with the kidney stone. And therefore the patient with the kidney stone waits and waits and waits. And some of them have waited now from March 2020. And there is damage done. The longer you leave untreated kidney stones, the more harm will come to that kidney and potentially could cause, in some cases, permanent kidney damage. So a so-called benign condition is not actually benign if you don't treat it.
And Chair, with your permission, I'll come in from a general surgical perspective. I think it is fair to say, and I suppose one of the reasons we are constantly challenging the system about continuing surgery is that some of the benign conditions that I treat, if you're on a waiting list for a gallbladder operation, you quite often get recurring bouts of problems with your gallbladder that necessitate coming to ED. But in a small number of those patients, you will get a very life-threatening necrotizing pancreatitis, which could mean you spend up to 1 year in a hospital. So we are seeing examples of people on our waiting lists who have presented with severe necrotizing pancreatitis that would not have presented had they had the gallbladder operation in a timely fashion. And I think we have to see it in the mix of the pressures that the system is under. We are following the FSSA guidance, and with your permission, I may bring Tim in, Chair. And that is a prioritisation system. But as you're aware, due to the number of people that would be deemed priority 2, i.e. need timely surgery, we had to further subclassify that in Northern Ireland into 2A, B, C and D. In other words, those with very critical need for a cancer operation being A and D being benign, but that is in no way suggesting that that is an algorithmic order of you do A before B, before C, before D. But the fundamental difficulty is we have a major issue of capacity, and the regional prioritisation group have been really trying their best to utilise capacity where it is to ensure that people get timely surgery, but it is extremely difficult. And Chair, with your permission, if I brought Tim in.
Yeah, thank you.
Thank you very much, Mark, and thank you very much to the Health Committee for having the opportunity to talk to you today. So I'm speaking in my capacity as Vice President of the Royal College of Surgeons of England, and as a college, our role really is to support our members and fellows across the UK in the very difficult circumstances that we find ourselves in. And as Mark has alluded to, there were very difficult circumstances before COVID came along, and they've been made very much worse by that. But we're very keen to work with all organisations to try and do what we can to help the situation. And Mark has alluded to the concept of prioritisation. This was introduced at the height of the first wave of the pandemic, when we recognised that access to operating theatres was going to be very short supply. And it was a way of being able to assess the relevant prioritisation across different surgical specialties. And to that extent, I think it proved effective because it's very difficult otherwise to compare apples with oranges. The difficulty has come that there's now such a huge backlog, particularly in Northern Ireland, that the numbers of patients waiting in those different categories are so large that they themselves, as you've heard, have had to be subcategorised, and that makes it extremely difficult. And it really demonstrates why we need to find a solution to try and deal with the backlog of surgery, but also to ensure that we can maintain surgical services. We know that hospitals are under extreme pressure because of emergency care, but at the same time, we do have to try to ensure that we can maintain as much surgical activity as we possibly can. And that's where the concept of separating out emergency and elective activity is so important.
Thank you. Okay, thank you. And I'm going to go to members actually, because I'm very keen that all members I'm very conscious we have a very experienced and knowledgeable panel, and I want to get around as many questions. We'll go around a quick run of questions from members, and if time allows, then maybe we can come back in if time allows another question or two. And Mark, I would appreciate it if you would direct, if there's a particular professional who's well placed to answer a question, if you could direct that would be useful. Or if members wish to direct their question to a member of the panel specifically, please do so. But I would just ask, in the interest of getting the most out of what's a very important session, I have to say, if I could ask everyone to be succinct in both in terms of questions and in terms of responses as well, if possible. And if there's additional information from another respondent, then so be it. But anyway, I'll go to Pam, our Deputy Chair, first, and then I'll go to other members. Go ahead, Pam.
Thank you, Chair, and thank you, Mark, and your colleagues for attending committee today on what's a really important issue, and we understand the pressures that you are under. It's clear that the situation in relation to elective care waiting lists is long past crisis point. It's quite distressing actually to hear the detail that you've presented to us today. But the fact that 1 in 4 people in our province are on a health waiting list is a sad indictment, I think, on government collectively, and we cannot continue to plug gaps with short-term budget allocations or policies that tinker around the edges of the current backlog. My first question maybe is towards Mark, and I want to ask you, Mark, given that COVID is likely to be with us for some time, how do we recover elective surgery?
Thank you very much, Deputy Chair. I think that COVID is going to be with us for some time, and if it isn't COVID, it will be something else. And we have known for quite some time that in a system that has elective surgery in the same operational facility as unscheduled surgery, that when we come into periods of pressure in unscheduled care, as we're seeing at the minute, the casualty of that is the beds are used for the emergency because they're in the department at that time, and that bed is therefore not available for the elective patient to come into. The critical care bed is used for the emergency, and therefore the critical care bed is not available for that person. And so that's why it is critical that in those surgical specialties where you can separate emergency surgical practice from elective, that we do so, and that we do it in protective environments, COVID light sites or hubs. In other words, that those centres, whether remote or within the same infrastructure as the acute, are protected, that the beds are protected, that the staff are protected, and that there is an efficiency in the pre-operative workup of those patients, that they aren't cancelled at the final minute because of a lapse in the pre-operative workup. So in other words, that they become centres of activity that aren't influenced by other factors. Clearly, Chair, there are some areas that isn't possible, and for example in Mano may want to come in terms of sort of neurosurgery, but by and large our plea would be we really have to ramp up protected sites. We call them COVID light at the minute because we're in the COVID pandemic, but we really have to do that to keep the recovery of surgery. And with your permission, Deputy Chair, I'll maybe bring Mano in.
Thank you very much. I'm a consultant neurosurgeon, and I work in amongst a low volume, high complexity specialty, and that encompasses colleagues in terms of also cardiothoracic, spine, other specialties that we are centered in one unit. The difficulty that we have is we're competing with everyone else, and our patients may not have a numerical number of greatness, but their outcomes are very much determined by how soon we see them and how our specialist nurses, our specialist anesthetic staff, our recovery is all centered around their care. Examples of this would include patients who are going to go blind, who are going to be unable to walk due to paralysis, or their brain tumours or other features by which they're going to succumb to this. The reality is the system at present allows the mix of scheduled and unscheduled, and allows this big mix to come in, and it makes those of us that are there to be able to deliver a service, we are really struggling to do so. And the moral distress that we've touched upon here is a daily dilemma and a daily distress for us all. Pure examples of this would be a patient who is going blind, a patient who's unable to walk, a patient who's going to die of cancer. And within a limited service, we as a body of clinicians have to decide who takes priority. Now, I would say that whilst our numbers are not as great as the other specialties across the cardiothoracic, spine, interventional, vascular, neurosurgery, this should not be the way things are now. We need action. We need the ability to protect our services, to allow those patients to have that expectant treatment, because the reality is they will go through the A&E department that is overwhelmed at present. And they know, and thankfully, our patients are able to go to a service and wait, and we can try to shoehorn them into the already stretched services, because that's our way of being able to get and operate on them. But their clinical condition has deteriorated. Therefore, their outcome will be worse. And we are here able to help, but with no capacity to do so.
And Deputy Chair, if you don't mind, I'll maybe bring Brian in to give you an example of what we mean by the hub or the benefit of that separate model. And Brian will bring a little short statement on Lagan Valley.
Thanks, Mark. Yes, Deputy Chair, Lagan Valley has worked very well for our specialty, but only for a subsection of patients within our specialty. So we opened Lagan Valley this summer. We were able to get new equipment, and we're very thankful to the Minister for investing in new lasers and new technology for Lagan Valley, and that has been really helpful. The staff, the nursing staff, I want to pay tribute to the nursing staff in Lagan Valley who have adapted to a whole new set of procedures, and patients have been willing to travel to Lagan Valley. And it's been a breath of fresh air for our surgeons. You walk into Lagan Valley in the morning, you say you're going to start at 8, there is no debate about beds, all the patients are going home, and you start operating at 8 a.m. It works really well. So our specialty can say very, very clearly that these high volume, low complexity surgical hubs work. They work well. And the Lagan Valley setup works for patients who are fit and happy to have a day case procedure. Our challenge now is to try and replicate that on a bigger scale, where we would need an elective site where larger procedures that need inpatient beds in a protected elective site would be the way forward. But certainly on the day case pilot that we've run in Lagan Valley, extremely successful, and we're running it now for the whole region, so that it doesn't matter if you want to have a urology procedure from Fermanagh to Ballycastle or Derry to Newry, you can have it in Lagan Valley. That's our direction of travel, and I believe that's the only way forward.
Thank you all very much for those answers. So just for clarity, are we talking about needing physically detached pathways or sites, or are protected pathways in the same location? Are they feasible?
In terms of that, it really, and I think if we look throughout the United Kingdom, it really is depending on the infrastructure that you have. Ideally, having a separate site. Again, it adds to the protection of it, but there are many centres throughout the UK that have protected hubs within the major teaching hospital that is also providing emergency care. But the critical component of that, Deputy Chair, is that it is a protected environment that in extreme pressures of emergency departments isn't opened up for the emergencies, because that really falls foul of what we mean by a protected environment. So certainly in Northern Ireland we could look to the future of having dedicated elective care centres that do not receive emergencies, or that emergencies go to other sites, or within the bigger complexes having protected environments. And I suppose the example that is glaring us in the face, that is under extreme pressure at the minute, is Musgrave Park. Musgrave Park was a regional green site, a regional hub dealing with elective orthopaedic surgery.
Deborah, go ahead.
Thank you to the panel there that's come to talk to us. There's been really stark warnings there in evidence that you've brought forward, and it is quite distressing, because obviously we're dealing with constituents who are on waiting lists. I think you've sort of touched on it there, Mark, in your last contribution, but have you any insights into whether patients in particular postcodes or trust areas have been disproportionately impacted by red flag cancellations or indeed wait times. And also in relation to that, I mean, we heard the numbers there in relation to the nurses. Is that Musgrave alone, just for clarity? And what is the picture across Northern Ireland? And why are those staff leaving? What is the main reason for those nurses leaving the service completely?
Deborah, thank you very much, and delighted to talk to you, and congratulations on your appointment to the Health Committee. I think in terms of postcode lottery, as a college, we're not cited on data that would highlight a major concern in terms of which particular trust you are treated in. But what we are aware of is, and have supported, is the regional prioritisation group work, which was exactly with that in mind, and that is that no matter where you are in Northern Ireland with your cancer, you should not be disadvantaged in terms of where you and the timeliness of receiving that treatment. There is no doubt that some of the centres in Northern Ireland are centres of regional activity, and so they are providing a district general hospital support plus a regional service, as well as the impact of COVID and have come under major pressure. But I think it's fair to say that every trust in Northern Ireland is under immense pressure. In terms of the nursing issue, I'm maybe, and before I come to that, I'm maybe going, with your permission, Deborah, bring Isaac in, really to look at the issue of paediatric access, and particularly the issue around the postcode, because Isaac will obviously look after paediatric patients in Belfast, but it is a regional service, and I maybe would be keen to hear Isaac's view on that.
Hello, my name is Isaac Phillip. Can you hear me?
We can
Very well.
Yes, we can hear you clearly here in the room. Isaac, we're not seeing you, but we are hearing you clearly. So yeah, go ahead.
Excellent. Okay, my name is Isaac Phillip. I'm a paediatric surgeon. I represent paediatric surgery and urology on the board, and I work at the Children's Hospital primarily, although there are sessions at the Ulster Hospital too. So I just wanted to, I've listened to the debate with great interest, and I know that a lot of work is being done to facilitate scheduled care and bring it up to speed. But as a member of the only dedicated children's hospital for the whole of Northern Ireland, I think even though our numbers may not be as impressive as the adult numbers that have been handed out in this discussion, as Manu has pointed out, many of our children need time-critical care. And if you don't intervene in the correct time, then there are consequences that would be there for the entire lifetime. At this point in time, our bed capacity is maxed out at about 110, between 100 and 110, although our funding is only for 97 beds, and we run close to 100% capacity on a daily basis. It is very difficult to get scheduled care in, and we have had several occasions where patients have actually come into casualty and actually camped overnight so that they could get into to have a bed in this hospital to get scheduled care done. And as I said earlier, many of these are time-critical procedures. Now, we also do daycare work at the Ulster Hospital, which from 2020 has been functioning between 20 to 25% capacity, and that increases the workload for us in the children's hospital, therefore. So we are managing to get our cancers done, and I know that several of my adult colleagues are even struggling to do that. We are managing to get our emergencies done, but as I said, the priority 2 upwards, it is a struggle to get patients in for lack of capacity. Our A&E waiting times have gone up by 15%, and even today an elective list has been cancelled because of lack of beds. I think the issues here are, firstly, I think we need to have some transparency with the general public in that the expectations need to be tempered as to what's going on. And I suspect, although most of them do understand that we are working within limitations, there is an emotional component to our practice, being pediatric practice. And it's not always easy to deal with these situations. We also have sickness and quarantine, and you are aware that the quarantine rules for staff members is slightly different from the general public. So these are the issues that we are facing now, and there are solutions that, with the help of the board, I have been able to put forward to the minister, and there has been willingness to help out. But I think we need continued support. We need some flexibility, and particularly reopening of sites where we can actually continue with activity despite bronchiolitis or COVID overwhelming the hospital bed situation.
Thank you, Isaac. And Deborah, your final question in relation to the nursing workforce in terms of the reasons why, with your permission, I'll hand to David Swain.
Deborah, can you hear me?
Yeah, thanks.
Well, first of all, like many of the issues we're dealing with today, this is not a COVID problem. This is a chronic problem which predated COVID. And many years ago, a health minister reduced nursing places in Northern Ireland, so it should be no surprise now that we're trying to find more nurses. So we have a chronic problem, and that problem, everybody describes it as being recruitment, then retention, and surely that's putting the cart before the horse. We need to really drill down into the reasons why nurses leave the service. No one wants to fill a bath, starts the taps running before they put the plug in, so we've got to stop losing nurses. We've got to make nursing attractive for people to stay in it, and then we've got to try and attract further people into it. Musgrave Park is a snapshot of that, but the problem is repeated across the province as a whole. What has happened to Musgrave Park, however, particularly during COVID, Musgrave Park as a specialty hospital with highly trained nurses who often stayed there for years and years and years, both in the wards and the theatre arena, has now been turned into somewhere that the nurses have been redeployed since the start of COVID, and they're voting with their feet. They're taking early retirement. They are leaving medicine completely. They are moving to jobs from which they can no longer be redeployed to areas within the Royal Victoria Hospital. So those figures that I mentioned with regard to the hundreds or so nurses in Musgrave Park, they were specifically Musgrave Park Theatres and Recovery. And I'll say we're now down to 14 nurses. But this is not just a Musgrave Park problem. The treatment of some of the Musgrave Park nurses has really sharpened the problem for us in Musgrave Park Hospital, and our difficulty is as a surgical specialty that sits between, for instance, Manu, whose work can only really be done in the Royal Victoria Hospital, and perhaps some of our general surgical colleagues whose work can be done in a range of hospitals around the province. Essentially, we have Musgrave Park, Craigavon and Altnagelvin, and elective surgery in all those areas have stopped, but everybody is struggling with nurses. Musgrave Park is particularly bad for a variety of reasons. Does that clarify the issue for you?
Yeah, thank you. You don't have any figures in relation to Altnagelvin and Craigavon in relation to the workforce there?
I can't give you specific figures for those units, I'm sorry, but I know from talking to my colleagues informally, they are having the same issues, particularly with redeployment, and the trouble with long-term redeployment is that people who are perhaps coming towards the end of their careers then decide to take early retirement. Other people who have an opportunity to move sideways to a different career or a different area do so. And so this is not a Belfast Trust or Musgrave Park problem. This is across the region. But fundamentally, we have to address the retention issue first, because until we do that and make nursing attractive to nurses, we're going to continue to have this problem coming on year as we face another crisis, as we invariably will.
Thank you.
And Deborah, we can provide you with a breakdown of figures, certainly that were part of the perioperative working group in terms of theatre nursing redundancy, nursing numbers and vacancies within posts throughout Northern Ireland.
Thank you, that would been useful. Thank you for your kind words as well. Thank you.
Thank you. And just as a quick follow-up to that, and that issue about exit interviews is one that has been raised, and I have raised myself with the Chief Nursing Officer here. I think it's vital that we find out why staff are leaving. And there's also a wider issue around the whole area of safe staffing, whereby when experienced staff like that do leave, you then create a mix on the ward or on the surgical team that doesn't have the full range of experience, and that puts pressure on incoming staff who also feel that they're put under undue pressure. And it has been raised with me recently, are any of you aware if we are doing intervention interviews, never mind exit, if we're doing interviews with people to say, listen, what would it take to keep you here? What would it take to get you that break you need? Where would you be prepared to work? Are we doing enough to keep people who are on the point of leaving rather than finding out why they're leaving? And I don't think we're doing that well enough. But are we seeking to find a way to retain them at that point?
Chair, I think that's a very valid comment as regard to interventional conversations in the nursing fraternity. I would not be minded of what the strategy is within that, certainly within the surgical fraternity, and I suppose what we can talk with confidence on is our surgical trainees, because we have certainly had to embark on massive intervention in terms of keeping our trainees focused on a career in surgery, and the reasons that they are disillusioned is they're not getting the operative experience, they're not getting the training, they're looking to their morally distressed consultant colleagues and wondering, why would I want a career in this? And I suppose that it is the importance of any surgical leader, and I the same for any nursing leaders and directors of nursing in the trusts, that you actually do exactly what you're saying, and that is intervene at an early stage. I think we know from this pandemic that multiple redeployments and instability in where you go into your working environment has led to this great degree of anxiety among our nursing staff, and as David has said, are leaving. And in fact, the number, albeit 533 nurses that have left their posts across the 5 trusts in the August 2021 story. It may be that some of those are redeployed to other areas, but I think if we had that number and ratio of surgical trainees leaving, we would be extremely concerned. And I think I may bring Tim in, if you don't mind, Chair, just in relation to interventions around retaining our staff, not just surgical staff, but nursing staff as well, Tim.
Yeah. And Tim, just before you come in, Tim, and if you could briefly, please, but also just to let you know, your sound is not brilliant, so if you can just be conscious of that and just be as clear as possible. Thank you.
I'm sorry about that. Can you hear me okay now?
We're hearing you there, yes, we are hearing you. Yeah.
Good, thank you. Yes, this is very much the same story in many respects that we're hearing as a college right across the United Kingdom, but I think the situation in Northern Ireland is particularly acute, as we've heard. And staff morale is very low, is a particular issue, and of course that has its own impact in terms of retention and recruitment. And as we've heard, it's across the whole of the surgical team. We know that there are some issues for senior medical staff in terms of their ability to reduce their hours if they wish to, or to stay in post to prolong their careers. We've seen others being a problem. There are some issues around pension arrangements, for instance. But it's a critical area to make sure that we retain the staff, because the training of staff really takes time. But the issue about training of surgical trainees is critically important. Mark has already said no training today, no surgeons tomorrow. But as we focus on the difficulty in providing a service, we must embed training into that service because for that very reason that we need to make sure we've got a service in the future. And it's very easy to focus on the service provision when there's a large backlog of work to address, but we must embed training within that process as well.
Okay, thank you. So I'm going to go to Alan then, and I have Colin indicating on the video conferencing. So Alan.
Thanks, Chair. Would the College agree that everything possible needs to be tried by the authorities here to contain the infection rate of COVID and to subsequently reduce hospital admissions? And how many elective procedures could be denied by an ICU bed being occupied by a long-term COVID patient? And I am aware that Northern Ireland does historically have the longest waiting lists for elective surgery in the UK, but are the current elective surgery throughput pressures unique to Northern Ireland, or are they been experienced all over the United Kingdom?
Thank you very much, Alan. Firstly, as a College of Surgeons, in relation to the discussion around COVID-19, obviously we don't have influence on policy there, but what I would say, and I'm sure my colleagues would agree, any strategy that reduces the impact of COVID-19 on a hospital will be beneficial to us as a group of surgeons in terms of trying to carry out not just elective surgery, but also time-critical surgery, urgent and emergency surgery. Because we are sitting in a situation at the minute where our ED departments have people with acute surgical pathology waiting 24, 48 hours and the like for the bed before they can have the procedure that is needed. In relation to the elective throughput in terms of critical care, in other words, a patient with COVID-19 in an intensive care bed, well, that's an intensive care bed that cannot be used for other aspects of health and social care. Now, we are mindful that there was an expansion of critical care beds to accommodate the COVID-19 pandemic, but the very discussion we've been having around allocation of staff to man those beds, that is staff that could be otherwise used in elective and time-critical surgery. And in answer to the second part of your comments, Alan, which I think is a very important concept, is that we as a body of surgeons have been looking at all aspects of where a patient can go after major surgery. And whilst the intensive care unit is needed for some, my example would be Mano and his extensive neurosurgery would go to an intensive care bed. Some of the major vascular and upper abdominal surgery would go to an intensive care bed. What we as a college and many others have been looking at is where else can we send patients that isn't an intensive care or it isn't even a high dependency unit, in other words, a step down from intensive care, but it's actually looking at other models such as PACU, where we have one up from the ward level of care, but we don't need that intensive care bed. So it's looking at all avenues where we can have capacity to carry out surgery. But you're absolutely right. A patient for many months in an intensive care bed with COVID is a large number of elective procedures. By and large, most elective critical surgery going into an intensive care unit would go into it for 24, 48 hours before returning to the ward. So you can calculate the number of procedures if someone is in an intensive care unit for a long period of time. And in regard to the final component, Alan, of your questioning around the backlog in elective surgery, is this unique to Northern Ireland? I think Northern Ireland is unique in that we have by far the worst waiting times, although our counterparts in other parts of the United Kingdom are now affected by that. And for a small statement, I'll bring Tim in.
Briefly, please, Tim.
Yeah, thanks, Mark. The same principles apply across the whole of the United Kingdom. It's just very much more acute in Northern Ireland. And as we've already heard, it applies across the whole of the United Kingdom. there were significant problems with increasing waiting lists and difficulty before COVID. COVID has very much accentuated that. So the problems are not unique, but much more acute in Northern Ireland. And although there's some general principles that we've seen introduced within England, Wales and Scotland, they do need to be tailored to local environments. So we can talk about principles that can be transferred, but the exact mechanism for dealing with the situation really is dependent on local environment.
Thank you.
Thank you, Alan. Colin McGrath, and just to remind members that we have a 2 o'clock question time, 2 o'clock, and we may lose members at that point. Colin, go ahead, please.
Thank you very much, Chair. I hope that everybody can hear me okay, and thank you to the panel. I'll try not to detain you or else I'll be accused of making those waiting lists longer, so I'll let you get back to work. But I also apologise as well because I sit on the Business Committee and I had to nip out in the middle of the meeting, so these questions may have been asked, and my apologies if they have been. The question I wanted to ask was that you make reference in the report that was given to us about hidden waiting lists and how the hidden waiting lists have the potential to cause a double of our waiting lists in the next number of years. So I was just wondering about what a hidden waiting list is, or what that actually is defined as and how that could have an impact. And I know there was some reference to the reduction in beds. And I note that from the report that you've given us as well that we're around about 1,000 beds less than where we were 10 years ago. And we're obviously told regularly in debates and in other the ministerial statements and others that because of innovation and being able to turn patients around quicker, that there isn't a requirement for as many beds as there was those years ago. But I was just wondering what your view as surgeons would be effectively to the question, if you had more beds, would you be able to do more surgery?
Colin, thank you very much. 2 excellent questions. I think the first one is about the hidden waiting list. Is we have been mindful throughout this pandemic that people have been holding back from coming forward, either because of fear of coming to a hospital environment or access difficulties or whatever. And as you know, and I think you've been on public record before, asking people to come forward if there is issues with health. And so for us, the worry is what is out there that we're not aware of, and what potentially is going to unfold when we have an opening up of all aspects where we have reduced the social distancing difficulties mean that only so many people are face to face at a clinic, the difficulties within general practice with social distancing, etc. So the hidden waiting list is what is out there that we actually aren't aware of. In terms of the beds, I think the issue of beds for us is that we do have beds, but as we have said before, those beds are trying to be all things to all people. So they're trying to be the beds needed for the very busy ED department to admit them to. They're trying to be the beds that we want for our elective surgery. They're trying to be the beds for chronic disease coming into hospital. And they are holding beds for patients who can't go back into the social care and community. And I suppose, forgive me, committee, for bringing up Bengoa and delivering together, but I suppose one of the key things for us is the shift to population health and where there is less reliance on beds. But certainly from our point of view at the minute, we need more protected beds to allow the continuation of surgery. I would say my ED colleagues would suggest they need more beds for unscheduled care to avoid those waiting times in ED. But certainly I think we could do with more beds, but probably at a premium we need more staff. Colin, I'm not sure if that answers your questions and if any of my colleagues wanted to come in. Do you mind, Colin, if Brian came in for a quick sec?
Yeah, I think it's about beds in the right places, Colin. I think beds in the correct area is what we're after. I think we were very clear that both for high volume, low complexity, we need completely separate sites, and that Lagan Valley model works. So the second model that we would be supportive of is a hospital within a hospital model. That's already working in Wales, and we've tried to do a version of that at the Ulster Hospital in Dundonald, and that is within that hospital building, you have zones that are completely devoted to surgery. That is, the nurses wear different uniforms. It's completely green. There is no mixing of COVID and non-COVID. You come in a different entrance and you leave a different entrance. And there are dedicated theatres, nursing staff on the wards, and HDU and ICU support dedicated to support that hospital within a hospital model. So I think that's the future. We need to develop hospital within hospital sites in Northern Ireland, and we need to develop high volume, low complexity COVID-like sites.
Thank you. Colin, is that you?
Oh, yes, that's perfect, Chair. Thank you very much.
Thank you, Colin. Do you want to come in after, Pam? Is it on this?
On this.
Okay, go ahead.
Thank you. I just want to come in with a wee supplementary question. It was around, I think, fascinating, this concept with the hospital within a hospital model. I'm just wondering, have you done any survey in terms of your staffing levels? Obviously, you've talked about the staff that have been lost to the system, but has there been any modelling done in terms of how many of those staff you could get back if they were assured they were coming to a green site or a hospital within a hospital which isn't impacted by COVID in particular, because we know the stress, anxiety that has caused. And also, are there staff or ex-staff that have been shielding that will come back to work on those sites if that is a guaranteed green site?
Pam, do you mind if I bring David in?
Pam, thank you. I can't, it's an informal survey, but I had a discussion with our nurse manager in Musgrave Park Hospital on that very question recently, looking at the 31 theatre and recovery staff who have left and will not return to the trust at this stage. And her thoughts are that it's actually a very low number, and there's various reasons for that. Some people who were coming towards retirement have finally decided this was their time, this was the final straw. I would have to say that in Musgrave Park Hospital, one of the issues is that our nursing staff are not confident that we, or indeed the Trust, could deliver them a guarantee that they would not be redeployed if they were to return.
And Pam, I may come in, if you don't mind, on the workforce appeal, and I would really encourage our Health Committee and Minister again that the concept that you've just articulated, Pam, is exactly what our passion was, which is call out to our retired colleagues and our shielded colleagues and say, we are not able to carry out normal duties, we're not able to carry out urgent duties, and we need staff to come back, and the guarantee that we will give them is that they will be in COVID green or COVID light sites. We will try all that we can to protect them with regular testing, isolation of patient, only bringing patients in that they're negative and PCR, and I think we need to really look at that workforce appeal again and go back out. My understanding is that there has been a call-up of staff, mainly administrative and porting staff, all very important for the system, but we really need to get that retired nursing staff and medical staff to come back in, and the only guarantee we can give them is you will not be moved back to some area of COVID management.
Okay, thank you. Orlia?
Yeah, thank you. So I suppose my final question was actually addressed there in terms of the one thing, what would be the one most important thing in terms of assistance to each of you in your respective areas right now at the moment. And I know it was covered around, maybe looking at those surgery zones within the hospitals, trying to get staff back, and then if you are able to get more sort of protected beds. So I'm just trying to think of practically, some follow-up that we can be doing with the department, with the Minister, on your behalf. So I've took note of each of those issues. My two quick questions then. One would be, are you aware of any plans? I know we're talking about the impact that redeployments is having on the retention of staff. Are you aware of any plans of further redeployments? I know that some clinics and services have been resumed throughout the COVID pandemic. Is there any plans to sort of downscale those again and to create maybe another phase of redeployments? And my second question is in terms of, you have mentioned around the capacity to deliver timely surgery, which is obviously critically important. And I'm wondering how you are finding the referral process with the independent sector and with the south of Ireland, and if that is, if that is sort of helping or assisting the system in any way, or on what scale it's doing so. Thank you.
Orlia, two really important questions, and I think I will address the first in terms of redeployment. It is certainly my understanding at the present time that I suppose lessons have been learnt, and that there is now in some areas a greater recognition that taking away theatre nurses as a first port of call to assist in ICU for COVID is not advantageous, and indeed I am aware that in several trusts other staff are brought in, trained up to be in those intensive care units, should it be nurse specialists from other disciplines, should it be allied health professionals from other disciplines, with the proviso that they're trying to keep theatre staff in operating theatres, and obviously you've heard today that that is not universal throughout each of the specialties. I think our fear is that as we come into a really exceptionally busy winter, where we are seeing greater pressures of unscheduled care, and again, this is where we as a society as a whole have a part to play, and it's back to Alan's comments. If COVID becomes a bigger problem in the winter with everything else, then there is a limited resource, there's a limited number of staff, and I suspect we will see the same redeployment of staff out of operating theatres and the reduction of time critical surgery. In terms of the use of the independent sector and cross-border initiatives, I think first of all, at this precise time, those centres have been what we call COVID light sites. So the use of the independent sector and the cross-border initiatives have been allowing people to have surgery. And for that individual, that is fantastic. For the system, in the short term, where we have a major capacity issue, that is also helpful, but that is not the long-term solution. And indeed, what none of us on this call want to see is a two-tiered health system in this country, where those that have will access private and those that haven't have to wait. So the long-term plan for Northern Ireland is radical reconfiguration of the existing infrastructure that we have. The buildings can't be doing all things for all people at all times in the way they did in the past, and we need to have centres of maximum elective surgical activity, and those centres may lose their emergency status. They may change the profile of their ED department and the very infrastructure that they once held dear. But the reaping benefit of all of that is that we will have the capacity to deal with the expanded waiting lists and the increased demands as we go forward.
Thank you.
Okay, thank you, Orlia. A couple of very quick ones, if I can. Hopefully they're quick answers, but if not, maybe you could forward on maybe some information to us, Mark. But in relation to, and we didn't get into much detail, in relation to the elective care framework that the Minister announced, and indeed your own 10-point action plan, what's the next key steps that need to be focused on to continue progress on those, or has progress been stalled, or is it continuing apace around those planning documents?
I think, Chair, as surgeons, we're probably very impatient individuals in that we see a problem and we want to fix it immediately. I think there is progress. I think we need more progress. I think that our quarterly waiting lists will show that our homework has been marked and that we do need to do better. I think we need to, as I said earlier, really relook at the staff workforce appeal. I think we need to be clear throughout Northern Ireland where those centres of COVID-light sites are going to be, and actually draw attention to how we staff those. And I do believe that a regional waiting list for Northern Ireland is also something we need to look at. We have 1.8 million of a population, and whilst we're mindful of 5 trusts, as Brian Dugan has articulated, people are willing to travel to get their procedure. So we need a regional waiting list so that we know, no matter where you are, whether you're in Ballycliffe or you're in Belfast, that you're on a waiting list and that you will get timely surgery. And I suppose, with your permission, Chair, I'll maybe bring Tim in, who's been that external ear to our conversation, to see if he has any small points to make in regard to your question. Tim, are you still on?
I think Tim is frozen.
Oh, Chair, I think Tim is frozen. Okay, so and maybe bring in one of my other colleagues, Brian. Any other comment just in relation to Chair around 10 steps, not 10 years, and what's needed to be done?
Yeah, I mean, I think I would emphasise the models that we've put forward. We know they will work. We've evidence at our recent college meeting about how successful this plan is in Wales. So learn from other areas, work on the models. But if there was one mantra, it's nurses, nurses, nurses. I think that has to come first. Training, really important. But if I was to leave one strong message, it would be concentrate on nurses, nurses, nurses.
And I suppose, Chair, we do have to be mindful that, particularly in somewhere like Musgrave Park, we have a major training situation now as well, in that because there is literally very limited elective activity, there is very limited elective trainee exposure, and given that that's a regional service. So whilst we have looked at all of our 10 steps and we're mindful that COVID has affected the ongoing delivery of the elective care framework, I think there are some critical incidents at this present time, and that is that we are going to have a major orthopaedic trainee dilemma at our hands if we don't radically address the resumption of orthopaedic surgery.
Okay, thank you. And listen, I know that David was hoping to get back in there in relation to some of the elements around training. Maybe we could follow that up in writing with you, just given that time has beaten us a wee bit here. There are also a number of other things that I think as a committee we could look at usefully doing. But for now, I could, just to allow us to complete that bit of work, I can allow yourself and your team there, Mark, to go ahead. But I want to thank you all for attending, for giving us your time and very valuable insights and knowledge into this area of work. And just, I suppose, to commit that we will continue to try to do all we can as a committee to ensure that those surgeries are given the priority and the planning and the progress that is so badly needed. So thank you all very much for attending this afternoon, and we'll see you again soon, and please take care. Thank you.
Thank you very much, Chair and Committee. Thank you.
Thanks, Chair.
Thank you all. Thank you all. Take care. Remember, I think there was a few things there we could be doing with getting an update. First of all, on the workforce appeal that was mentioned there, an update on what numbers have been and what further benefit we could get from that.
Chair, on that workforce appeal, that notion of actually concentrating it, putting the appeal out to people to come to green sites, because obviously there are shielders, there are people retired, maybe vulnerable in terms of age groups and whatnot, that actually that the COVID work is not an option.
So members content, that's one element of it. I think also we should ask the department, have they the ability, or are they planning to do anything along the lines of intervention, interviews with staff to see if staff can be retained, and also I'm still not getting a great sense of exit interviews. They might be getting done, but I wonder could we get an update on how many exit interviews have been done and in what circumstances they're done and how the information is captured. The other thing I think that was raised there was the regional waiting lists. I think an update on what progress has been made in relation to that would be useful. And one of the issues that I would have liked to get into there, but we didn't have time, was around the whole data systems and the monitoring. And it links in with Encompass and that, but I wonder is there a way that we could seek, an update in terms of surgery, what data systems are being looked at to improve the flow of patients through the system.
And I know, Chair, last week with the GPs, they said that they had a wealth of information that could feed into Encompass. So I do think that we need to have a session on that data collection and on Encompass and where we are with it and where it's at.
Yeah, okay, I think that's something we should. Anything else, members, being indicated by way of actions or clerk from this session that... No, I think that's a fair bit. Thank you, Alan. Colin, go ahead, please.
Yeah, thanks. So, I was just wondering, can we ask something about the breakdown of beds that if there are 5,672 beds, could we get the breakdown of how many of them are actually for surgical purposes? Because they are definitely making a case there that if there was more beds, they would be able to put more people through and then bring the waiting lists down. And they did talk about the sort of arguments that there are internally between different sections, but it might just be good to see, are we looking at 20% of our beds for surgery or 30% or 50%, or just to get some sense of that?
Yeah, I think we can actually, but I do think also, and I think Mark Taylor referenced it, even if you don't have the staff, having the beds isn't. So maybe we could also double that up with a further request as to when a proper workforce plan in terms of the different professions, what the needs are, and how those training places are going to be facilitated in the future. So I think a briefing on that from the department, or certainly a written briefing in the first instance, to include beds and staffing. Down to that, Colin? Yeah, go ahead, Pam.
Just on the surgical trainees, I mean, that was a stark reminder, no trainees today means no surgeons tomorrow. And the fact that, the surgeries have been, to all intents and purposes, in many cases, halted for long periods of time. And what happens to those trainees? And are they tempted to go elsewhere?
Yeah.
In order to work and get the experience that they need to...
So what's your...
profession. So, I certainly think we should be asking the department what they're doing to address that, to ensure that we're not going to lose those trainees. And why would anybody come in to train in a profession when there's no opportunity to actually do the physical training?
Yeah, members content with that suggestion. And maybe even just a general update on the elective care framework, on progress with the elective care framework, even in light of COVID, but I still think we still need to keep an eye on exactly what progress is being made or lack of in that respect. Yes, Arlia?
Yeah, it was just on the point of, see the issues that were raised around Musgrave Hospital. I don't know if it's worthwhile, even just run that past the Minister and the Department to see if they are aware of the scale of those nursing shortages. If it was 31 or something have left and, they only have 14 out of 100. So it's just to see, because you were talking about what interventions are taking place and interviews and all that there, but at a department and ministerial level, maybe just ask the question, are they aware, are they dealing with someone from Musgrave to communicate what's going wrong there?
Yeah, fair enough. Members content with that? Okay, listen, members, obviously something that would merit much more attention, and we will have to make space for it to keep our finger on this particular pulse. It's really a serious concern. Some of the things we're hearing there today are very worrying and require attention. But thank you for that, members. Anyway, so all it leaves for me today now is to the date, time, and place of our next meeting, which will be on Thursday, coming the 2nd of December, via Starleaf. Okay, members. Thank you.
Okay.
Okay.